Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling necrotizing enterocolitis, much more commonly known as NEC, and we're very lucky here at Pulse Check today because we get to walk through a case with my colleague and medical counterpart here at Archer, our Chief Medical Officer, Dr. Steve DeMayo, who just so happens to be a neonatologist that treats NEC all the time. So welcome, Steve. Thanks for being here.
Hi, Morgan. Excited to be here. Let's jump into it.
All right. And we're recording from the NICU today. So it's a good day to be at Pulse Check. I love it.
Yes.
First things first, I always start us out with a practice question. So don't give away the answer yet, Steve. For all you listening in, save that what you think might be the answer for later. We will circle back at the end of the episode and Steve will help break down why the correct answer is correct. Okay, here we go. We have a nurse in the NICU caring for a 29-week preterm infant that is receiving gavage formula feeds. Before the next feeding, the nurse notes a moderate green gastric residual and a new increase in abdominal distension with a firm, tense abdomen. Which action should the nurse take first? We have A, document the findings and recheck that residual in 2 hours. B, continue the feeding at a slower rate. C, stop the feeding and notify the provider. Or D, administer simethicone as prescribed for gas discomfort. All right, tuck away what you think it might be. First, let's get into talking about really what is necrotizing enterocolitis. So Steve, kick us off in basic terms, like what really is NEC? What is going on under the hood?
Yeah, absolutely. So necrotizing enterocolitis, or NEC, as you may hear me call it, is really a multifactorial inflammatory disease of the bowels that occurs in premature infants. It's actually the most common GI emergency that we encounter in the NICU. Necrotizing enterocolitis can occur in up to 5% of babies born less than 1,500 grams, a category that we call very low birth weight infants. And so despite all the advances in neonatal care that we have, it remains a leading cause of both morbidity and mortality in the NICU.
So pretty common. If you decide to go into being a NICU nurse, you're most certainly going to see this at some point. You maybe even see it during clinicals. So Steve, kind of walk us through like step by step, what's the patho, what's going on when this disease process occurs?
So as I mentioned, the science on necrotizing enterocolitis is changing every day. And NEC seems to be a multifactorial inflammatory process where the endpoint is essentially necrosis of the bowel wall. And that necrosis of the bowel wall can cause the baby to go into systemic inflammatory response or shock, and can even lead to intestinal perforation and surgical emergencies from that standpoint. But the mechanisms that lead to that bowel necrosis can be related but varied. The first is that the premature intestine doesn't function in the same way that a mature intestinal epithelial lining functions. And so you can think of your intestinal lining as a barrier to protect it against things like bacterial translocation from the rest of the body or the abdomen. And so we think that bacterial translocation and actually infection is part of this. It's also something called dysbiosis, disruption of the normal gut microbiome that should set up shop inside the human GI tract, but doesn't happen in preterm infants. And then also, we think there's something wrong with intestinal blood flow and the signaling that goes along with that. So localized ischemia related to blood flow changes that happen in utero during development, and then when we actually ask babies to digest enteral feeds, probably all contribute to the final pathway, which is that necrosis of the intestinal wall.
Got it. Okay, so that's great to understand multiple factors at play here, but they're all kind of leading to one endpoint, which is ischemia, which ultimately leads to necrosis. So remember, every single cell in our body needs blood. That blood brings oxygen and nutrients. whether it's this bacterial translocation or a lack of blood flow or one of the other factors that Dr. DeMayo pointed out, they're all leading to less blood going to the intestines. The intestines then literally start to die. That's what necrosis of tissue is, right? They start to die off. They can't do their jobs. The intestine's job is to help us break down and process our food. So my next question for you, Dr. DeMayo, is what does that then lead to? Like, what are we watching for? What starts to happen in these babies when their intestines are not getting blood flow, becoming ischemic, and then necrotic?
Yep. So, I always try to teach nurses, you want to first be aware of whether your patient has any risk factors for NEC, because that'll help you as a nurse inform your assessment and your communication of what you're seeing to the medical team. So prematurity by far is the biggest risk factor. So we're always on the lookout for NEC in babies born less than 28 weeks gestation. We also know that formula feeding is a huge risk factor. So put another way, the provision of human milk, whether that's mom's own breast milk or donor breast milk, is very protective against NEC. But if your baby is formula feeding exclusively for whatever reason, that's a risk factor. We also look for things like early antibiotic exposure. So it turns out that if your patient had to be on long-term antibiotics early in life, that can lead to necrotizing enterocolitis later in life. And lastly, there's a lot of maternal factors. So issues like intrauterine growth restriction, suggesting that there's maybe some ischemia in utero that sets up bad regulation of the intestines later in life, and also maternal preeclampsia, which again is related to placental blood flow. So always think about those things when you're evaluating your patient on a day-to-day basis. Now, I divide the signs and symptoms of NEC into early and late. The early signs can be fairly non-specific and can include things that we see in lots of NICU babies that don't have NEC. One of those things is just feeding intolerance or increased gastric residual. So either the baby is not digesting enteral feeds that are being placed in the stomach, or pre-feeds, you're finding that there's a lot of feed left in the stomach when it's time for the next enteral feed. We also look for things like abdominal distension, bloody stools, and then non-specific findings like temperature instability or hypothermia, an increased frequency of respiratory events like bradycardia or desaturation events, and decreased activity or lethargy.
So a lot of the more specific signs to me, if I'm thinking abdominal distension, bloody stools, an increase in residual, those are all pretty specific, telling me this baby's gut is really not doing what it needs to do, right? Food is left in its belly, belly's getting bigger, the intestines are clearly irritated if we've got blood going into the stools. But then there's also some non-specific things that say just, hey, I don't know exactly what's wrong, but this baby's not happy for some reason. We're having these B's and D's, bradycardia and desaturation episodes. They're lethargic. They're not acting like themselves. Systemically, we know, hey, something's up. And for me, this is where your like nurse gut or intuition comes in, especially if you've been taking care of the same baby for, say 3 or 4 shifts now. And you're like, they're usually super happy. They're resting after their feeds. They're fine. And now they're really irritated as soon as they start being fed. That might tell me something is up there as well.
That's right. It can be very non-specific, and that's why calling to attention those changes in vital signs or changes in abdominal exam is really important so that the medical team can evaluate whether further diagnostics are needed. Which brings me to the next point, which is that with the first common test that's ordered to evaluate for signs of NEC is a plain abdominal X-ray. And on that X-ray, we're looking for things like dilation of the bowel loops. We're looking for things like fixed loops of bowel, so areas where it's very dilated but doesn't move on subsequent films. And then a later sign that's actually the diagnostic sign for NEC on X-ray is something called pneumatosis intestinalis. And that essentially is a bubbliness that we can actually see on X-ray, which is from the necrosis of the intestinal wall. So if you see pneumatosis intestinalis on X-ray, you've made the diagnosis of NEC. Now, after those non-specific signs that we talked about as sort of the early signs, if those are missed or if the patient is progressing in terms of severity of their NEC, we can sort of move into the late or more severe signs. So this may look like things like actual abdominal wall discoloration, so a reddish or purplish hue to the abdomen, actual signs of abdominal tenderness, So pain upon palpation or guarding from the infant. We mentioned the signs of pneumatosis on X-ray. This can actually progress to a perforation of the bowel, which shows itself as pneumoperitoneum or free air inside the abdomen. And then very late findings may look similar to shock or sepsis. So systemic hypotension or low blood pressure requiring IV blood pressure support, or other signs of sepsis or peritonitis.
Okay, yeah, all those things that come with like a massive inflammatory response, because that's ultimately, if that baby's intestine, especially if it perforates, but even just with necrosis, they're going to be quite inflamed. So that inflammatory response. All right, great. So are you ready to walk us through a case? Really bring this to life here? Tell us a story. Let's go ahead and start off with a client scenario. Give us the lowdown. Tell us a little bit about the baby, their kind of basic info, and then walk us through what the case progressed from there.
Yeah, absolutely. So let's imagine that you're taking care of a former 26-week premature infant who's now 6 weeks old or 32 weeks corrected, who are off IV fluids and feeding entirely via nasogastric tube, a combination of maternal breast milk fortified with human milk fortifier. And upon your pre-feed assessment, you note a significant gastric residual, 50% of the prior feed still present in the bowel, along with tachycardia and abdominal distension. So you report these findings to the medical team, who order a plain abdominal X-ray that shows dilation of the intestinal bowel loops and signs of pneumatosis intestinalis in the left lower quadrant.
Okay. Okay.
That satisfies the diagnosis of NEC. So the next question is, what orders can you anticipate in the treatment of this patient?
Yeah. And now I actually have a question for you before we jump into what we're going to do from here.
Sure.
Is you said, hey, we have a significant gastric residual. 50% of that last feed was still in the belly when we went to give the next feed. So, as a neonatologist, can you define for us what is a significant gastric residual? Is 50% the threshold? Where do you want to be notified? What do the guidelines say is important to escalate?
Yep. So residuals are tricky because there are some units that don't actually check gastric residuals anymore, but certainly anything over 50% of the ordered volume from the prior feed could be considered a sign that there is some type of feeding intolerance. Other signs of feeding intolerance could include actual vomiting or emesis. So if the baby has emesis after the feed, or if that emesis is bilious, that suggests that there is an ileus or problem with intestinal motility related to the early signs of NEC. And then
Totally.
lastly, we always want
It's
to be on
not
the
moving
lookout
forward like it
if it's not
should.
moving
Yeah, it's
forward,
moving back.
correct?
Totally.
There are some patients that are clinically silent until they have that first bloody
Mm,
stool. So of course, we're always looking for hematochezia in the diaper.
got it. Got it. Okay, perfect. So we've noticed these early signs, gotten an abdominal x-ray, the diagnosis of neck has been made. What happens from there?
Depending on the severity at the time of presentation, the care is mostly supportive. So the immediate interventions are we stop enteral feeding, so we make the patient NPO. We stop all of those feeds. Depending on the degree of intestinal dilation, we change that NG tube or nasogastric tube from a feeding tube to a tube that can be used for decompression. So we'll often put that NG tube to suction. We'll support the baby with IV fluids. So if your patient has no access, we'll place an IV to provide maintenance IV fluids. And then typically start broad spectrum antibiotics. So these would be antibiotics that will cover things like gram-negative and anaerobic bacteria, the type that tend to set up in the gut and can be undergoing that bacterial translocation that can happen because of that impaired intestinal barrier that we talked about before. Now, the supportive care could also include treating any other symptoms that you're seeing related to a baby that may be displaying signs and symptoms of shock. So you may have to increase their respiratory support if you're having increasing frequency of those bradycardia or desaturation events. They may need non-invasive ventilation like CPAP again. They may actually need to be intubated and placed back on mechanical ventilation. We may need to support their cardiovascular status with fluid resuscitation and IV blood pressure support. And then you can also anticipate frequent lab monitoring and X-ray monitoring. So things like complete blood counts, coagulation studies, and blood cultures, as well as serial abdominal X-rays to follow the progress of those intestinal findings. A surgery consultation is warranted on an emergency basis in case of pneumoperitoneum or free air.
Got it.
Or if there are babies with clinical deterioration, despite all that supportive care we've spoken about, sometimes the necrosis of the intestines has progressed to the point where an exploratory laparotomy, where a surgeon actually opens up the abdomen to look for signs of necrotic bowel or dead bowel, is the right treatment course, because they can resect that segment while you continue your resuscitation of that patient.
Okay, yeah, go ahead and get that dead tissue out of there. So it sounds like, from a nursing perspective, I notice these things, something's going on with the gut. We get our diagnosis of NEC. My priority needs to be to hold the phone, not put anything else into that baby's belly, and go ahead and get the provider involved so that they can do their assessment, order some diagnostics, and see what's going on. It might not always be neck. We might have other, things going on, and we do end up continuing to feed. But if we do get that diagnostic of neck, we really need to keep that belly empty so that it can heal. We can kind of, take all of those other actions you mentioned, like potentially antibiotics, supporting any other symptoms that they have, so that that gut can be reperfused and get back to where it needs to go.
That's exactly right. You can anticipate all of those things we talked about: stopping feeds, getting additional access depending on what the current access situation of your patient is, anticipating fluid management, frequent laboratory work, and frequent abdominal imaging.
Perfect. Perfect. Well, I think that brings us perfectly back to our practice question. So I'm going to pose it back to the students, Steve, and then I'll have you jump in with the correct answer and talk us through why. Why would that be what we need to do for this client? So once again, we've got a nurse in the NICU, and they have a 29-week preterm infant receiving gavage formula feeds. Before the next feeding, the nurse notes a moderate green gastric residual and a new increase in abdominal distension with a firm, tense abdomen. Which action should the nurse take first? We had A, document the findings and recheck that residual in 2 hours. B, continue the feeding at a slower rate. C, stop the feeding and notify the provider. Or D, administer simethicone as prescribed for gas discomfort. So we'll give you a second, say your answer out loud, jot it down, and we'll bounce it over to you, Steve. What should that nurse do first?
Morgan, the correct answer should be C. Stop the feeding and notify the provider immediately. And again, to your point, the most important thing is early assessment and early diagnosis to assure the best outcome for these babies. And even if it turns out that those subtle signs of feeding intolerance that were described in the vignette turn out not to be NEC, it's better to take this conservative approach, proceed with the diagnostics to assure that you don't have a baby that's at risk of rapid clinical deterioration.
Got it. Perfect. So we are going to hold that feed. We're going to keep their belly empty so that it can take a little break and kind of dig a little deeper to see what we've got. That's really your key takeaway from our episode here on NEC, is that we are going to assess for those early signs, those residuals, the feeding intolerance, abdominal distension, all of those things Dr. DeMayo pointed out we're going to be on the look for, especially if our kiddo has risk factors such as prematurity, formula feeding, etc. And if we do see a change, if we do suspect, hey, something could be going on with their belly, we are going to hold those feeds and let the provider know. So thank you for sharing all of your wisdom with us, Dr. DeMayo from the NICU. Any last thoughts on NEC that you want to leave our students with today?
Just remember, NEC is the most common intestinal emergency in premature babies, and it requires rapid diagnosis and supportive treatment to minimize the most severe morbidities and even mortality. And above and beyond that, it can be a really scary time for the families of these patients. So being an attentive nurse and supporting not only the medical needs of the baby, but the social and emotional support of a family struggling with a sick infant in the NICU is why NICU nursing can be so challenging, but also so rewarding. So I hope to see many of you in the NICU in the future as future neonatal nurses.
I love it. Wonderful. Well, thank you for joining. And thanks to all of you for listening in to Pulse Check. Again, I'm Morgan, and we'll see you next time. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.